Thank you for the opportunity to provide an overview of the BE-FREE trial, or benzodiazepine-free cardiac anesthesia for reduction of postoperative delirium. BE-FREE was recently published in JAMA Surgery, and there's an excellent podcast that provides an overview that can also be accessed at the link available on the screen. So to provide a bit of background, delirium is an acute disorder of cognition that affects at least 15% of patients after cardiac surgery. Delirium poses a serious problem for both patients and healthcare systems. Patients with delirium stay longer in hospital and increase costs to the healthcare system. Beyond the system level costs, at the level of the individual patient, delirium is so traumatizing that 30% of patients who have delirium go on to develop post-traumatic stress disorder as a result. Further, beyond the fact that many believe it to be an entirely psychological entity, patients who develop delirium have a 32% increase in their odds of in-hospital mortality. Benzodiazepines are a medication that, when given before and after cardiac surgery, have been associated with delirium, such that guidelines from both the Society for Critical Care Medicine and the American Geriatric Society recommend they be avoided in the elderly and patients at risk of delirium, including cardiac surgery patients. However, benzodiazepine use during cardiac surgery is very common, and this is largely because the administration of benzodiazepines is thought to prevent the experience of intraoperative awareness or being awake during surgery, although this has not been proven in any trials consistently. As such, benzodiazepines are given to approximately 90% of patients undergoing cardiac surgery, although practice is widely variable. No trial had previously examined the effect of restricting intraoperative benzodiazepines on postoperative delirium. This gave rise to our study question: does an institutional policy of benzodiazepine-free cardiac anesthesia reduce the incidence of delirium up to 72 hours after cardiac surgery? And this was really a pragmatic question about routine care. We chose to answer our question using a cluster randomized crossover trial design. Cardiac surgical care is provided to a relatively homogeneous set of patients with similar comorbidities who fall within a similar age range, and these patients are undergoing a homogeneous set of procedures where perioperative care and outcomes are similar across patients. Because in homogeneous populations such as this, care is more efficient when it is standardized, cardiac surgical care is typically provided using standardized care pathways, including preoperative order sets, postoperative order sets, and perioperative plans of care. In contrast to this very standardized care, anesthesiologists choose whether or not to give benzodiazepines to patients having cardiac surgery, primarily based on personal preference. Given this striking contrast, we felt that the best way to test the impact of restricting intraoperative benzodiazepines was through random alterations in standard institutional policy, similar to how cardiac surgical care is usually provided. And again, as I said, this was really a pragmatic question about what should be the default routine practice in this patient population. This slide provides an illustration of what we did within the trial. If you look at the top part of the slide and you think of the red people as anesthesiologists who always give benzodiazepines and the blue people as anesthesiologists who never give benzodiazepines, you can see that whether or not a patient receives benzodiazepines primarily has to do with whether or not their anesthesiologist is a red person or a blue person. what we did within Be Free is we took current practice and we didn't really change it. We just standardized it within each institution. So if you see each row in the lower part of the slide, you can see that what we did is by randomizing hospitals to use one standard institutional policy or another, we were able to evaluate what happened in institutional delirium rates at the level of each participating hospital. The two intervention arms that we compared were the restricted benzodiazepine policy, which mandated no routine administration of intraoperative benzodiazepines, but allowed for exceptions to be made if clinicians thought there was a strong patient-driven reason that a patient should receive benzodiazepines. And we compared this with the liberal benzodiazepine policy, which mandated the administration of at least 30 micrograms per kilogram of midazolam equivalent to all patients undergoing cardiac surgery. Once again, recognizing that in some cases, clinicians would choose not to apply this policy if there was a contraindication within an individual patient. For example, if a patient was allergic to benzodiazepines, exceptions could be made to this standard institutional policy. Hospitals were randomized to apply the two periods over the course of 12 to 18 4-week crossover periods. Each hospital was randomized to all periods, but we blocked in periods of 2, and this was to minimize period effects. 9 hospitals completed 18 periods, 2 hospitals completed 17 periods, and 9 hospitals completed 12 periods. The reason for the variation in periods across centers is because we undertook an interim analysis midway through the trial, which we had to pause during the COVID-19 pandemic because of a slowdown in cardiac surgery cases. Because we were concerned that the COVID-19 pandemic may have impacted our sample size estimate based both on the number of cardiac surgical cases as well as potential changes in our intra-cluster correlation, we undertook a blinded interim analysis whereby we re-estimated our sample size and determined that in order to maintain statistical power, a subset of sites needed to complete additional periods. This is described in greater detail in the supplement to the main trial paper. This picture really just shows an example of what we did within the trial. Each row is a hospital, and each column is a period. And you can see that across all of the participating centers, policies were applied at random, where the orange boxes represent liberal periods and the blue boxes represent restrictive periods. Our primary outcome was the incidence of delirium assessed up to 72 hours after cardiac surgery by nurses using validated scales in routine clinical care. The assessment of delirium is a quality standard that's mandated by accreditation, and so delirium is routinely assessed in all cardiac surgery ICUs in Canada. We also assessed patient-reported, clinically documented awareness as a safety outcome. Post-hoc, we looked at the number of positive delirium assessments. And we also looked at ICU and hospital length of stay, as well as in-hospital mortality as secondary outcomes. We analyzed our data using a logistic mixed model, following an intention to treat approach. All models included fixed effects terms for period, used random effects to account for within period intra-cluster correlation, and adjusted for age, sex, emergency surgery, history of heavy alcohol use, and history of home benzodiazepine use. And as I said, our primary analysis used an intention to treat approach. In terms of trial execution, we started the trial late in 2019, but because of the COVID-19 pandemic, had to pause several times, such that while our original timeline to complete the trial was approximately a year and a half, At the end, it took us more than 2.5 years to complete trial enrollment. The total budget for the trial was approximately $850,000 Canadian. We included 20 hospitals in Canada and the US, and a little bit less than 20,000 patients. 9,827 patients were randomized to undergo surgery during restricted policy periods, and 9,941 patients underwent surgery during liberal policy periods. Overall, adherence to the policy was excellent, such that the policy was applied in 92% of patients, reflecting the dedication and commitment to the clinicians in participating hospitals to answering this important clinical question. The mean age of participants was 65 years, similar to most cardiac surgery trials, and 1/3 were female, again representing the normal cardiac surgery population. 7% of patients had a history of home benzodiazepine use, and 5% had a history of heavy alcohol use. The majority of patients were going isolated coronary artery bypass graft procedures, followed by 17% of patients who were undergoing isolated valve procedures. The remaining patients were undergoing some combination, for the most part, of CABG and valve procedures, although there were some other more unusual procedures that didn't fall within either of these categories. 8% of patients were undergoing emergency surgery. Across all patients, the mean cardiopulmonary bypass time was 116 minutes. Despite the existence of guidelines, 16% of patients got preoperative benzodiazepines. Intraoperatively, only 9% of patients got benzodiazepines during restricted periods, 93% got benzodiazepines during liberal periods, and when patients did receive benzodiazepines, they received an average dose of only 4 milligrams. Postoperatively, 11% of patients received benzodiazepines. This slide shows anesthetic management because many would wonder, in the absence of benzodiazepines, did patients get something else that could potentially affect delirium? And the short answer is no, not really. There were essentially no clinically important differences in anesthetic management across the two policy periods. There was a statistically significant difference in the dose of etomidate when patients did receive it. However, this was a very small difference in dose that was statistically significant, but not clinically significant, according to most clinicians. Within our primary analysis population, 14% of patients developed delirium during restricted policy periods, and 14.9% of patients developed delirium within liberal policy periods. With an adjusted odds ratio of 0.92, a 95% confidence interval with an upper end of 1.01, and a p-value of 0.07. There were no reported cases of intraoperative awareness. And when we looked at the number of delirium assessments that were positive, so this means of all of the delirium assessments occurred, the number that documented delirium, patients who had surgery during restricted policy periods had significantly fewer delirium assessments that were positive, with an adjusted risk ratio of 0.87, an upper end of the 95% confidence interval of 0.98, and a p-value of 0.02. This is just a histogram that shows the difference in positive delirium assessments within 72 hours after cardiac surgery. The orange bars represent the number of positive assessments during liberal periods, and the blue bars represent the number of positive delirium assessments during restricted periods. And you can see that across all time points, there were fewer positive delirium assessments within the patients who underwent surgery during restricted periods. With respect to our secondary outcomes, there were no differences in ICU length of stay, hospital length of stay, or in-hospital mortality when comparing restricted benzodiazepine management with liberal benzodiazepine management. Recognizing that adherence to policy was not 100%, we went on to complete several post-hoc analyses. First, we excluded patients who had surgery during restricted policy periods who had received benzodiazepines within 24 hours before surgery. In this analysis, the incidence of delirium during the restricted policy periods was 13.7%, compared with 14.9% in liberal policy periods, with an adjusted odds ratio of 0.88, an upper end of the 95% confidence interval of 0.97, and a p-value of 0.01. When we looked solely at patients managed according to intraoperative policy, once again, there was a statistically significant reduction in delirium with restricted benzodiazepine administration, with an adjusted odds ratio of 0.9, an upper end of the 95% confidence interval of 0.99, and a p-value of 0.02. When you further remove patients who had received benzodiazepines within the preceding 24 hours from the restricted arm, the results become that much more positive, with an incidence of delirium in the restricted arm of 13.4%, an incidence of delirium in the liberal arm of 14.8%, and an adjusted odds ratio of 0.87, with an upper end of the 95% confidence interval of 0.96 and a p-value of 0.005. We looked at several different subgroups and found that the effect of the intervention was similar across ages, as well as within patients who had a history of heavy alcohol use or a history of heavy, home benzodiazepine use. And all of this data led us to conclude that by intention to treat, a restricted benzodiazepine policy did not reduce postoperative delirium. However, restricted benzodiazepine use was not associated with any adverse events, and no cases of intraoperative awareness were reported. Given that we had seen an on-policy analysis with an approximately 10% reduction in delirium with benzodiazepine restriction, and an effect size that increased the more that benzodiazepine exposure was eliminated, we concluded that restricting benzodiazepines during cardiac surgery could be considered. Thank you for your attention.